morning. I'm Babak Larian, um, here to do a hyperparathyroidism question and answer, a live question and answer session. Very sorry I'm late this morning. I had some technical problems that basically life, I, and so I couldn't be on time. I apologize for that. For those of you who waited, I really appreciate it. In any case, we do have a few questions to start off with, and let me delve into that. So, the first question is from Azadeh Azadeh. It's been 5 months since my parathyroid surgery. The surgery was successful and my test results are normal, but I still experience pain in my hip pelvic area. This pain includes soft tissue discomfort. I can't tell exactly whether it's muscle, tendon, or something else. My thigh bone hurts, bending is difficult for me, and sitting is painful. Before the surgery, I had severe pain and spasms in my lower body to the extent that I was almost paralyzed. Unfortunately, I haven't become completely pain free, and life has become very difficult for me. I still experience tingling and pins and needles sensation, especially in my toes, as well as prickling feeling in different parts of my body. I had the same symptoms before the surgery, but they were much more intense back then. Before the surgery, my condition had deteriorated badly, and this hormone had affected my entire body. Dear Azadeh, I'm sorry you're going through this. Recovery from hyperparathyroidism is quite a challenge. Um, uh, and it's really that way because the disease affects every aspect of your body. So, in terms of nerve function, let me show you. So, our nerves function by sending signals that go down their membranes and down their fibers, and they get to either the next nerve or a muscle, and then tell the muscle to contract or pass on information from nerve number 1 to nerve number 2, which gets passed on. Now, when the signal comes down the fiber, when it gets to this endpoint, which we call a synapse here, which is this thing, the synapse is this connection there for the signal to pass through either to a muscle or the next nerve. The way the signal is passed on is that once the signal makes its way down the fiber and gets to the end, it opens up calcium channels. And when the calcium channels open up, the calcium elements rush into the cell from the outside. So there's more calcium on the outside as compared to just a little bit on the inside, okay? So if your body wants a calcium of 9.0, right? If that's where your set point for calcium is genetically decided, and all your life you're trying to be at a set point of 9.0, and then you get hyperparathyroidism, and that set point changes now to a set point of 11.0, let's just say, okay? And now your calciums are hovering around 11. Now, when you were at 9.0 and a signal of magnitude 90, right? A 90 signal came down, it would open up 10 calcium channels, all right? 10 channels would open up, and 90 elements would rush in, and that would equate to equivalent of 90 strength 90 neurotransmitters going across here, right? And the signal to the other side would be 90, right? But if you open up 10 channels and your calcium is instead of 9.0, 11, 110 calcium elements come in, a signal neurotransmitter of magnitude 110 goes across, and the signal that the second nerve gets is 110 rather than 90. I'm grossly simplifying, of course. But that shows you that the nerve signal that goes through is not necessarily accurate or efficient. And so these accuracies build up in time, and your nerves function less. So some of the nerve symptoms you have is because these nerves have been functioning abnormally for many, many years, right? And generally speaking, most of the patients I see have had this disease for many years before they're identified. And then diagnosed, they finally get to a surgeon and they get treated. So that many years they've lived in this abnormal state, right? So once the condition is corrected, like yours has been, you've had a successful surgery, these nerves that are functioning in this inefficient way have to start functioning more appropriately, right? And so the nerves in our body, each nerve is not connected only to one other nerve, it's probably connected to a multitude of nerves. So there's all these cross-connecting networks, both in the brain and everywhere else in our body, that have been malfunctioning and adapting to this malfunctioning environment, right? And then once you correct it, they all have to normalize. So it's not uncommon for people who have lots of symptoms that persist for a period of time, for a long period of time. And the longer you're in this abnormal parathyroid state, in the hypercalcemic, hyperparathyroid state, the longer your body will take to rebalance, readapt, and get back to its normal. So it's not very unusual for someone who's had hyperparathyroidism for a long time to have, like yourself, experience a lot of symptoms that don't seem to have completely gone away. All right? And I do surveys of my patients all the way up to the 4-year mark after surgery. And I often find that the patients do much better at year 1 as compared to 6 months, as year 2 as compared to year 1, and even at year 4 compared to year 2. So the improvements can continue, okay? Now, the other issue is that the parathyroid hormone itself also has an impact, right? There's PTH receptors. Let me see. There are PTH receptors all around our body. Let me find it, right? Okay, so there's PTH receptors in the bone and kidney. There's PTH1 receptors, and then there's PTH2 receptors in the brain, in the limbic system, in the hypothalamus, in the pancreas, right? In the area that produces insulin, in our cartilages, in the adrenal glands, and heart muscle, right? So all of these are getting super stimulated too by the elevated PTH. That's a constant elevation, right? So that's also a factor in how you feel and how you recover after the surgery is done. Excuse me. Now, yes, it could be that your pain is nerve related and your nerves are recovering. And it could be that your pain is cartilage related and some of the cartilages in your joint are still overreactive and because of the PTH receptors that they have. Those are all possibilities. But it's also possible that you have an underlying trauma to the tissue, to the nerve, muscle, bone, that was supremely exaggerated by the hyperparathyroidism, but there still is a problem. So I really encourage you to see an orthopedic doctor so they can look and assess these things for you to see if you have an underlying issue that also can be rectified and corrected, right? And you may have a tear in a tendon that in your hip that's really giving you additional pain, and that can be affected by physical therapy or something like that. So I would encourage you to do both. Don't lose faith. Your recovery takes a while, okay? Good luck. I find often that patients come to me and they feel like they've read online that someone had surgery and they immediately felt better, and that does happen, but it is more of an exception where you come out of the operating room and you feel like $1,000,000 and everything you had is better. Generally speaking, the bone achiness is the first thing to get better in the operating room because immediately your PTH comes down, but everything else takes much longer, right? From a few weeks to a few months to sometimes even a few years, right? And having some realistic expectations about what you can get out of this surgery is important because it can be very disenchanting when you suffered for so long and you do a surgery and you're not immediately better. And that doesn't necessarily always happen. It takes a while, okay? Good luck, Azadeh. But definitely see an orthopedic doctor to see if there is other issues that can be addressed and to help you along faster. All right. Joanne Roper. Hi, Dr. Larian. Do you think malabsorption like autoimmune atrophic gastritis could cause hyperparathyroidism? Yes, it can cause secondary hyperparathyroidism. Let me show you. So, So the parathyroid network is an interesting one. It has a lot of feedback loops. So the calcium in our body, majority of it is in the bones. So 98% of the calcium in our body is in our bones, right? 1% is in the bloodstream, which is why it's red, and 1% is in tissue, muscle, liver, skin, nerves, everywhere else. 1%. So majority is in the bones, right? So you have 4 parathyroid glands that are constantly looking at the calcium level in the blood only, not in the bone, not in the tissue, okay? And when the calcium level goes down in the blood, it produces more PTH. PTH goes to your bones and tells your bones release calcium into the blood. PTH goes to the kidneys, tells your kidneys absorb more calcium from your urine. Don't let the calcium go so easily. PTH also activates this enzyme in the kidney that changes the inactive form of vitamin D, vitamin D3, the one that comes in a supplement form that you take or is in salmon, egg yolks, and so on, and you also create through your sun exposure in the skin, and transforms it into calcitriol 125 dihydroxyvitamin D3, which is the active form that does all the work of the vitamin D as it relates to the calcium balancing system. And so vitamin D goes into your intestines and increases the absorption of food from absorption of calcium from food from 20% to 80%. So without vitamin D, you're only absorbing 20%. With it, you go up to 80%. It also has a feedback loop that says to the parathyroid glands, okay, I'm here, vitamin D is here, simmer down. You don't need to be as active. I got this. I'll absorb more calcium from the food. I'll have the kidney absorb more calcium from the urine, and we're going to be okay, right? And these feedback loops exist. Now, if you have a malabsorption, right? So, if you have an intestinal issue, right? So you have true gluten intolerance, autoimmune atrophic gastritis, where you're not absorbing vitamin D and calcium well, right? So those numbers are low. So your calcium and vitamin D is low. So if your calcium is low, right, calcium absorption is low, then your parathyroids are going to react by producing extra PTH, right? If your vitamin D is low, which means you have less of this to transform into that, so you have less of this, you also have less suppression of the parathyroid glands, so your parathyroid glands work even harder. So this is secondary hyperparathyroidism. You get when you have malabsorption syndromes in your intestines and you're not absorbing as much calcium or vitamin D, you get malabsorption syndrome that causes a false elevation in parathyroid hormone, and your parathyroid hormone, as it goes up, your calcium goes up, and you get secondary hyperparathyroidism. So Joanne goes on to explain, I had B12 of 2.7 years ago and iron deficiency. I understand vitamin D gets knocked down as well. 2 years later, my calcium started to rise, but my doctor ignored it for 8 years, and I finally diagnosed myself with parathyroid adenoma. This affects your ability to make HCl, so you can't absorb iron, hydrochloride. Okay. Or many bits and minerals, especially fat soluble. So if you're low on vitamin D and therefore not getting calcium, your PTH will draw from your bones since you're the high calcium. Just wondering about your thoughts on this. Thank you. Well, I agree with you. My thought is that you can get secondary from malabsorption, and oftentimes people have all 4 glands get enlarged. So they get hyperplasia from this, right? And rarely they'll have a hyperplasia that is reversible because secondary, not tertiary, but they may develop an adenoma on top of it too. which sounds like that's what you had. Okay? Joanne, I highly encourage you to make sure that your calcium and vitamin D levels in your bloodstream are normal and maintained. Vitamin D, fortunately, has a sublingual form, so it doesn't depend on absorption through your intestines, so you can take it that way. Calcium, I think there's one European country that makes a calcium that's supposed to be absorbable. I don't, through the mouth, I don't know if I trust it, but there's options out there. There's also IV calcium infusions that can be done, right? So any which way you need to be able to get your calcium and vitamin D numbers normalized so you don't have extra PTH in your system would be helpful to reversing secondary hyperparathyroidism, right? Moving on to Emily, 10th. Let's see, Emily IO324. Okay. How inconsistent labs calcium high than normal but have inconsistent labs calcium high than normal but have calcium in the urine? Advice. So Emily, the way to look at these numbers is to look at both calcium and PTH, right? So the relationship between calcium and PTH for someone who has normal calcium function follows this inverse curve. And this inverse curve has an inflection point, which we call the calcium set point, right? So this is the set point. In this patient, the set point is 9.5. So if the set point, if your calcium in your blood goes from 9.5 to 9.4, you have a 30% increase in PTH. That extra PTH goes to your bones, tells your bones to release calcium, and your calcium goes up back towards the set point, right? If, on the other hand, you overshoot and your calcium goes to 9.6, right, then you have a decline in PTH to allow your kidneys to filter calcium out. That way, you have your calcium go from 9.6 back down to 9.5. So that's how the system works. So is it possible for someone who's normal to sometimes have a calcium that's abnormal? Yes. But if you don't have the PTH as being a very low number, you're not going to know that that's just part of your routine normal behavior, right? Or you may have a calcium that's really, really in the lower range of normal, right? And then if your PTH is high at that point, that's also appropriate, right? So you have to get calcium and PTH all done at the same time, fasting and at 8 o'clock in the morning, and Emily. And you also have to make sure you haven't taken biotin for a week before doing the blood test for calcium and PTH, because biotin interferes with a machine that laboratories use to check PTH, and it can give you a false lower PTH, right? Now, if someone has hyperparathyroidism, they may have a curve that looks like this. Let's say their set point is 10.5, right? And this person will have high calciums, right? And will have this high calcium, right? Any number of high calcium numbers, but this person may also have a normal calcium. But if you don't have a PTH number to see that the PTH is really high at a high normal calcium, you won't know that this person is normal or abnormal, right? Comparing this to a normal person's curve, same calcium, right? The same calcium. In this scenario, the PTH is really high. In this scenario, the PTH is very low, which tells you this person has a normal parathyroid function and this one is abnormal. Okay, so check it out. The fact that you have high 24-hour urine calcium tells me that your kidney recognizes whatever calcium number you have as being high, right? Not enough to diagnose hyperparathyroidism, but certainly an added clue as to what's going on with your parathyroid system. Excuse me. Henri B. I'm a woman, 47 years old. The value of parathyroid hormone is 154, but by vitamin B12 is 9. Well, vitamin B12 has no bearing on your parathyroid number, but parathyroid hormone of 154 is extremely high. And so I would again encourage you, Andre, to check your calcium and PTH fasting and at 8 o'clock in the morning, along with your vitamin D, D as in David, right? To see if there's an abnormality there that persists, okay? And that can help you diagnose hyperparathyroidism. Emma Toner 123, post-op, would you recommend taking multivitamins, and if so, which type and brand? I do. I always give, this is what I have my patients do after surgery. I put them on this regimen, right? Based on their calcium before surgery, I put them on a regimen of calcium supplementation for 3 weeks. And every week, the amount decreases, the amount of calcium that they have to take. I also have them take magnesium, right? The calcium, I use Citracal because I find Citracal to be less upsetting to the stomach, right? For those 3 weeks. Magnesium, I've been using Nature Made, but I have no preference, right? There's a lot of magnesium out there, and there's a lot of good brands, okay? I also use arnica and bromelain, right, to decrease the swelling and thing. I encourage you, if you have bone loss, to also use vitamin K2, and there are dropper forms of vitamin D3 and K2, and I think that's a good combo because the absorption is more consistent. It doesn't have any kind of malabsorption issues in the intestines. So that's what I would encourage you to do. Okay? Best of luck, Emma. All right, let's see. We have some questions that have come in now. Let me take a look here. All right, Kathleen Perry Ortiz. Dr. Larian, I had one adenoma removed 5 months ago and was successful since all numbers returned to normal. But I have a small 1-inch patch of swelling still under my scar. Surgeon sent me for ultrasound to check for seroma, but results said no fluid. Have you swelling lasting this long? No, I have not. I have seen swelling above the incision, right? So if you were to look here, this is the incision, right? And after the surgery is done, usually about 3 to 4 days after surgery, you'll start to notice kind of a rounded bulge above the incision that about a month goes away. If you have a bulge underneath it, and the bulge above it is because the fluid in the skin that normally goes through gravity, goes down towards the heart, is interrupted by the cut, so that fluid sits around here and swells this area up. The fluid around it is able to go, but the fluid that was going through that area of scar stays, and in about a month, the new channels form, and this fluid leaves, and then it's gone. So if you have swelling underneath this area, one of the things that I've seen is that this is the clavicle, and this is the joint of the clavicle, right? Clavicle and joint. I've noticed that in people who have hyperparathyroidism, sometimes you get inflammation in this joint, right? So right here, there's pain right there, and you may get swelling there. So you may have inflammation in your sternoclavicular joint, right, causing swelling on that area. I would see an orthopedics doctor to check for that, especially if you've done an ultrasound and you see there's no fluid there. Or massage underneath. If the fluid collection, if the swelling is purely here, massage in sideways and downwards to try to force the fluid to go in other directions. You may want to get a lymphedema massage as well and see if that helps. But if it's a little bit to the side, underneath and to the side, more towards the joints of this clavicle, then you may have arthritis or inflammation in that joint. And that I've seen a fair amount. Since I was since I had osteoporosis at the time of surgery, what are the chances my bone density go back to better level of osteopenia better 1 year after surgery? I usually check the bone density at a year and a half because 1 year may not be enough, but the chances are immense. Right? I'm going to show you one of my favorite research studies as it relates to parathyroids, and that's a study that came out of Columbia University. Okay, there we go. This was done over a 20+ year period. There was 116 patients. Half of them, 59, decided they were going to have surgery, and 57 decided they do not want to have surgery. Interestingly, the calcium numbers were not too different, 10.8 here, 10.5 there, not statistically significant. But the PTH number on this side was 144, and on this side was 116. So the people who had a higher PTH had more symptoms and more inclined to choose surgery. Anyways, all of the people who had successful parathyroid surgery with the calcium and PTH normalizing, all 100% of them had improvement in bone density. And their bone density was 10% stronger 15 years later. So 15 years after surgery, their bone density was 10% stronger as compared to before surgery. So, and this is if they weren't taking osteoporosis medications or actively doing weightlifting exercises. So if you've had bone loss, I encourage you to do weight-bearing exercises. Meaning, if you don't like lifting weights, get one of those weighted vests that you wear with weights on your arms. You've seen people who walk with weights on their arms, and use that as weight-bearing exercise for yourself. If you like and enjoy weightlifting, and that can be very helpful. Hiking with weights, all of those things really, really help. And I would do the bone density study at a year and a half. Endocrinologist has me at least on 1,200 milligrams between food and supplements daily, new DEXA scan in 1 year. I would do the scan at 1.5 years, right? 1 year may be too early and may disappoint you if the numbers don't improve much, but 1.5 is more likely to give you the improvement you're looking for, right? Or at least that you're on the right trajectory. And there's no harm in having extra calcium in your system under the situation where you have osteoporosis, because your bones are deficient in calcium, and the more you provide, the more they're going to be able to incorporate, especially with weight-bearing exercises. Good luck, Kathleen. You're on the right path here, and you're asking the right questions, most important. Rachel Kinney. Is it true that those who've been on benzos in the past have a harder recovery from disease after successful surgery? Yes. Unfortunately, yes. So much so that on patients that I have that have been taking benzos regularly, I try to get them to quit benzos for a month or two completely before having parathyroid surgery, because I've noticed in some of my patients who have these long-term debilitating symptoms, a big commonality has been the use of benzos on a regular basis before surgery. And so I have seen it. I haven't seen any studies on it, but I've seen it, I've noticed it, and I really encourage you to all of you, anybody who's on benzos, I try to encourage you to get off of them. They are exceedingly good for very acute short-term stressful events, like loss of a family member. You're just having a hell of a time getting through it. The benzos help you get through. So you take it for a few days, maybe a week, and then you move on, right? That's what they're designed for. Taking them longer than that changes your brain chemistry so much so that it may have long-term impacts on the quality of your existence and functioning, okay? So, Rachel, good question. Stay away from those things as much as you can. Laura Given one Schritz. I'm about 8 weeks out, 2 additional tumors removed, also one had removed at age 21, and having a lot of back pain. I'm still taking 1,000 milligrams of calcium carbonate, 1,800 milligrams of D3, and 125 milligrams of magnesium glycinate. Last blood were calcium 9 and PTH 37, so the numbers look good. I also have osteoporosis, having eye, facial, and body twitching and spasm. Should I increase calcium and magnesium? If you have osteoporosis, then I would encourage you to increase your calcium intake. right? I would go to roughly 2,000 milligrams a day, okay? Magnesium, I would go to 250 milligrams twice a day. And then Laura goes on to say, I'm in more pain, back pain, than I was before surgery. That's unusual, and I'm sorry you're going through it. It's possible that as your bones are remineralizing, they're gonna feel the pain. It's like growing pains when kids are having growth plates that are growing, right? It's possible that you're having that. It should hopefully diminish in time, okay? But yes, I would change your calcium. I would increase your calcium and magnesium intake. I would also take 125 micrograms of vitamin K2. That helps your bones as well. I would, despite the pain, I would be active. The more active you are, the the, the more your bones will remineralize, and faster. And especially if you've seen a spine doctor, a back doctor, and you know there's no actual spine issues, it's just pure osteoporosis, then that in time will definitely get better. And Laura goes on to say, my back pain is caused by long walks and light biking. I'm thinking my bones need time to heal before I start back exercising. Yeah, so I would say do shorter walks. Um, you know, do as much as you can without causing discomfort. Um, that's really important, right? Being active is important in rebalancing and also telling your bones that they need to get stronger, but not overdoing it to the point where you're becoming debilitated. Okay, it's a tough road, Laura, and it's not something that people talk about um, in online so much as they should. That the road to recovery is not necessarily a quick, smooth one. It can be a little bit rough, but there's a light at the end of the tunnel that you will have definite improvements. Okay, very good, my dear. Um, that is the end of the questions that we have today. If you guys have any other questions or concerns, don't hesitate to let me know. I'm very happy to respond. I'm not only happy to respond to you guys, but I actually oftentimes learn from you guys because you'll ask questions I haven't thought about, so and force me to go investigate things that I haven't thought about before, which really helps me. So this is a bi-directional thing, and I thank you all. Have a wonderful day, and I'll see you next month.